Okay, we can start now. 1 second. Okay. So, assalamu alaikum everyone. My name is Ahmed Tayyib. I am a second year medical student, and today I'll be giving you a session on anatomy alongside Mustafa Ali. We'll be giving you high yield questions on high yield concepts, and this session shouldn't really be like a revision session. You shouldn't depend on the session for revision, but rather a reference point to see which areas you're weak in or how hard the questions will be on the exam. So this should be more of like a reference um, kind of file. So my contact details are here, and Mustafa's contact details are here. And if you have any questions, do not hesitate to contact us. So this is what we're going to be talking about. I'll be doing the odd numbers, Mustafa will be doing the even numbers, but I will be doing the first half, inshallah. Okay, let's start with thoracic wall and blood supply. And by the way, we've covered everything. I know you have 11 lectures, but we've condensed some of them into one objective, so don't worry about that. So, thoracic wall and blood supply. A patient presents to the clinic with severe muscle pain, followed by coldness or pallor in the upper limb. Imaging shows the presence of a cervical rib. Compression of which of the following structures leads to the presentation of these symptoms? You can just type in the chat. Okay, so the answer is B. Now, for the person who said A, this is called the thoracic outlet syndrome. And typically when you have a pancreas tumor, which is a tumor at the top of your lungs, or a cervical rib, these structures, they compress the lower trunk of the brachial plexus, firstly. So the upper trunk of the brachial plexus is just wrong. And secondly, even if it was the lower trunk of the brachial plexus, it would lead to more tingling and numbness. But A is just wrong because it doesn't compress the upper trunk. Subclavian vein is wrong because it doesn't lead to pain. It leads to congestion, passive congestion, which leads to backup of fluid and would lead to edema. And so when you compress on an artery, it leads to ischemia. And this patient is suffering from what you call ischemic muscle pain. There's no oxygen going to his muscles in the arm. So he's suffering from ischemic muscle pain. And this is the reference slide. Next question. A 16-year-old African-American male presents to the ER with a gunshot wound. The bullet penetrated the fourth intercostal space near the sternal border on the right side. If left untreated, which of the following complications is most likely to occur? Oh, okay. The answer is A. Oops. The answer is A. Okay. So the bullet penetrated the fourth intercostal space near the sternal border on the right side. 1 second. Is it clear now, my screen? Okay. So the bullet penetrated the fourth intercostal space near the sternal border on the right side. So since it's on the right side, this immediately excludes anything to do with the heart. So B and C are wrong. Okay. So this is a diagram of basically the vasculature of the thoracic wall. And if you look here, so this is for a second, this is the fourth intercostal space, and this is the sternal border. And you can see here an artery lays very intimate to this anatomical region. This artery is called the internal thoracic artery. Now, when something penetrates this internal thoracic artery, it leads to bleeding, and this bleeding accumulates in the thoracic cage, which is basically the pleural space. Hemothorax, so hemo means blood, and thorax is basically the thoracic region, so your pleural space. So when you have a buildup of blood in your thoracic cage or your pleural space, we call this hemothorax, okay? B and C, you exclude it because it says the right side and the heart is not on the right side. And this is the reference slide. So the internal thoracic artery runs from the first to the sixth intercostal spaces. Next question. A 72-year-old woman presents with swollen veins visible on the anterior chest wall. She reports a feeling of tightness in the chest. Imaging reveals an obstruction in the superior vena cava. Which of the following vessels is most likely to provide collateral circulation in response to this obstruction? Okay, so the answer is C. So, uh, this might seem scary, collateral circulation. So collateral circulation is just basically backup circulation. So which of the following vessels is responsible for providing backup to the superior vena cava? So the question is saying there's an obstruction in the superior vena cava, okay? And it's asking which of the following vessels will compensate for this obstruction, okay? So the main function of a vein is to bring blood back to the heart. And since there's obstruction in the superior vena cava, we need another vessel to bring the blood to the heart somehow, through some other route, okay? Now, we have subclavian vein and internal thoracic vein. Why are these wrong? So the subclavian vein joins with the internal and external jugular to make the brachiocephalic, and the brachiocephalic join together to form the superior vena cava, right? So it doesn't provide any backup circulation. If anything, it gets obstructed alongside the superior vena cava, okay? What about the inferior vena cava? The inferior vena cava doesn't really help the superior vena cava. It doesn't have any direct anastomosis with the superior vena cava. So you see this vein here branching off the superior vena cava. This vein here is the azygous vein. And the azygous vein, so when there's obstruction in the superior vena cava, the blood flows up here, but then it flows down the azygous vein, and it anastomoses with this vein here, which goes up to the inferior vena cava, taking the blood back to the heart. So the answer is azygous vein. A patient has swelling and pain in the upper chest and neck region. Imaging reveals a mass obstructing lymphatic drainage from the left thoracic duct. Where does the thoracic duct normally drain into the venous system? Okay, so the answer is D. So this is a basic recall question. You have the cisterna chyli, which is a ball starting in your abdomen, and then the thoracic duct carries lymph from the cisterna chyli all the way up to this junction here, okay? And it's specific, it's important that you mention it's the angle or the junction between the left internal jugular vein and the left subclavian vein. It's not just the left subclavian vein or the left internal jugular vein. So these two are really good distractors, but the correct answer is the junction between these two. And another name for this angle is the left venous angle. And this is the reference. Okay. A 25-year-old athlete is diagnosed with a rib stress fracture after an increase in upper body exercises. Which part of the rib is most likely to be fractured given the structural weakness? The answer is C. Okay. So this is you learned this in lab as well. I oh wait, I don't have a diagram. Okay. Anyways, the costal angle is the weakest part of the rib. And why is that? It's because the costal angle, it's not protected by fat or muscles the same way the rest of the rib is, okay? So when there's damage to the anterior to the costal angle, it leads to a typically fracture because in this area you have no muscle or fat protecting it or cushioning it. So the costal angle is the weakest part of the rib. A patient has a fracture at the tubercle of the seventh rib. Which vertebral structure does this part of the rib normally articulate with? The answer is B. Okay, so the ribs, so typically, other than the first rib, ribs articulate with the vertebra corresponding to its number and the vertebra above it. Okay, so the seventh rib articulates with T7 and T6. However, the question is asking, the patient has a fracture at the tubercle of the seventh rib. And if you see here, the tubercle, which is a bony projection, articulates with the transverse process of the vertebra, which is the same number as the rib. Okay, so the seventh rib, the tubercle of the seventh rib, always articulates with the transverse process of T7. Okay, what about T6 and T7? Doesn't the rib articulate with T6? Yeah, it does, but not at the tubercle. It articulates with T6 at the head. So the head articulates with these costal demifacets. You have an inferior facet, which is found on the superior vertebra, which in this instance is T6, and it articulates with the superior facet of the inferior vertebra, which is T7 in this instance. So the seventh rib, yes, it does articulate with T6, but at the head, not the tubercle. The tubercle always articulates with the transverse process. And a nice way to remember is the tubercle begins with T, and the transverse process also begins with T. So TT, so tubercle transverse process. Okay. Next question. A 45-year-old patient presents with sharp localized pain along the right sixth intercostal space. Which of the following best describes the origin and pathway of the intercostal nerve involved? The answer is B. So with these questions, they're pretty long, but there is a key word which is right sixth intercostal space. Okay. So the sixth intercostal space is in your thoracic region, obviously. And so looking at the options, vagus nerve doesn't really make sense, and neither does cervical spine or brachial plexus. Okay. And the intercostal nerves, they are derived from the thoracic spinal nerves. Okay. And an important thing about the pathway is that it runs along the inferior border of the rib in the costal groove. Okay. Why is this important? Because there are common anesthetic procedures when you want to anesthetize the thoracic region, you need to avoid the inferior margin of the rib, okay? Or else you'll risk damaging the neurovascular bundle below the rib. So you always inject the anesthetic so on the superior margin of the rib. Okay. Coronary circulation. This lecture is relatively easy. There's just some main clinical concepts you need to remember, like left dominant, right dominant circulation. And it's generally it's just recall. So let's start. A patient's cardiac angiogram shows a significant blockage in the posterior descending artery, PDA or PIA. In a left dominant heart, which coronary artery is most likely the source of this vessel? Okay, so the answer is B. So the okay, so it's not A because you would be right if it said right dominant heart, but it says left dominant heart. So if we look here, so this is a right dominant heart, this is a left dominant heart, and you can see so let's orient ourselves first. Okay, so this is the right coronary artery, this is the left coronary artery, and you can tell this is the left coronary artery because this is a large artery descending on the anterior surface of the heart. So this is LAD, okay? Now, it says left dominant, so why not LAD? Because it comes from the left coronary artery as well. Well, LAD is mainly responsible for sorry, I'm on the wrong diagram. So LAD is mainly responsible for supplying blood on the anterior surface, okay? The left coronary artery branches off into LAD and the left circumflex, and the left circumflex wraps around the heart and goes to the inferior wall or the posterior surface of the heart. And then the left circumflex gives rise to the PIA, so the posterior descending artery or PDA. See, if it was a right dominant heart, you would be right. It would be right coronary artery. But since it says left dominant heart, it comes from the left coronary artery, specifically the left circumflex artery. Okay, next question. Oh, during a coronary angiogram, a physician notices a blockage in the middle cardiac vein. This blockage would impair venous drainage from which area of the heart? Okay, so the answer is B. So this is also basic recall. The middle cardiac vein, it runs along the posterior descending artery or PIA. Okay, and we know that PIA it's in the name posterior descending artery. It's found on the inferior wall of the heart. So the middle cardiac vein runs with PIA, and so it's responsible for draining blood from the inferior wall or the posterior surface of the heart. And a way I like to remember is that PIA is the second biggest artery in the heart. So uh, the middle cardiac vein is gonna accompany PIA, whereas for the anterior wall of the left ventricle, that would be the great cardiac vein because it accompanies LAD, and LAD is the biggest artery in the heart. That's how I like to remember it. Okay. Which of the following represents the posterior descending interventricular artery, or PIA? Okay, so the answer is B. By the way, so one thing that is common in our exams is that they mix up options like this, and then see the arrows pointing at D. Some people just put D and they get it wrong. So be careful of that, firstly. Secondly, I'll just explain. So first we need to orient ourselves. So this is the superior vena cava. This is the inferior vena cava. And so we know we're looking at the heart from anteriorly. So this artery here is the right coronary artery. This is the left coronary artery. And if we go around posteriorly, this artery descending the posterior surface of the heart is the posterior descending interventricular artery, or PIA. Finally, um, wow, a 60-year-old male presents with symptoms of angina and is diagnosed with coronary artery disease. The physician explains that a structure responsible for draining deoxygenated blood from the heart muscle itself empties into the right atrium. Which structure is primarily responsible for draining venous blood from the myocardium? So the answer is A. Okay, so the question says, draining venous blood from the myocardium, so from the heart itself. So B and C are just wrong because they drain blood from the periphery, okay? Whereas the pulmonary veins, they bring blood back from the lungs and bring it into the heart, but they don't actually drain venous blood. So D is also wrong. And it's a basic recall question. The coronary sinus, you can see this big fat blue vein here. It inserts into the right atrium here, and this is the coronary sinus basically, and it's responsible for draining blood from the heart. Okay, nose, larynx, and trachea. So I've seen this lecture and it's really dense, like really dense. One piece of advice I would give you guys is don't go over the lecture multiple times. Rather, go over the lecture once and do as many questions as you can from your batch, from 16th batch, 15th batch, whatever, okay? Do as many questions as you can and you'll get a grip of what questions the doctor will actually ask. It is a really dense lecture, but you should do exam committee questions to get like an understanding of how to answer the questions. And one book I recommend you guys to do questions on is Grey's Anatomy. It's a really good book for this lecture. Okay. A patient has problems in his nasal cavity leading to the block of the superior meatus paranasal opening. Which paranasal cavity is affected? Okay, the answer is B. So these diagrams are really good for like, you know, understanding the drainage system. So you have concha. Concha are like shelves. So this is superior concha, middle concha, inferior concha. And then the meatus are just what's underneath the shelf or the concha. So this is the superior meatus, middle meatus, and inferior meatus. Now, one might think that the frontal sinus and the anterior ethmoid sinuses, they're the most superior sinuses, right? So why don't they drain into the superior meatus? Well, it's more to do with the proximity. So notice how the middle meatus, it's like it's very like deep inside here and is closer to the anterior ethmoid sinus and the frontal sinus than the superior meatus is. So the frontal sinus and anterior ethmoid sinus, because they're so close to the middle meatus, they drain into the middle meatus. Whereas the posterior ethmoid sinus is very intimate to the superior meatus, so it drains into the superior meatus. Okay. The vocal cords, or the true vocal folds, are located within which part of the larynx? The answer is B. So this is just a basic recall question. So you have the supraglottis, the glottis, and the subglottis, and you find the vocal cords here in the middle, which is the glottis. So the vocal cords are basically they're a gate, basically. They facilitate breathing and speaking. And a way I like to remember is that the glottis begins with G, and so does gate. And what acts as a gate in the glottis? It's the true vocal cords, or the true vocal folds, or the vocal cords. Um, okay, moving on. If an object is accidentally inhaled, it is more likely to enter the right main bronchus than the left. Which of the following anatomical features of the trachea and bronchi explains this? Answer is A. Okay, so if an object is accidentally inhaled, it's more likely to enter the right main bronchus. Why? Because it's shorter and more vertical. Okay, why is that relevant? If it's shorter, it has a shorter distance to travel, so it's easier to get lodged, firstly. And secondly, if it's more vertical, it's easier for it to fall into the right main bronchus than if it was more horizontal, like the left main bronchus. So that's why when you have a 5-year-old child enter the ER, they aspirated an object, you typically suspect that the object is lodged in the right main bronchus. And that's because the right main bronchus is shorter so the object takes less time to travel, and is more vertical, so the object just falls straight down into the bronchus. It doesn't like, if it was horizontal, it would be harder for it to get lodged. And finally, lung anatomy. So for Dr. Olena's lectures, I recommend you do her the barcode she does at the end of each lecture, because she typically likes to put them in her exam. She likes to repeat her questions. So definitely do her barcode questions and use BRS, especially BRS anatomy. All right, let's start. A 62-year-old patient presents with a history of lung cancer and difficulty breathing. Chest imaging reveals a mass located at the apex of the left lung. What symptoms are you most likely to observe in this patient? The answer is C. Okay. So a mass located at the apex of the left lung, we call this a Pancoast tumor. And a Pancoast tumor can typically lead to two syndromes. You have thoracic outlet syndrome and Horner syndrome. Now, the actual pathophysiology of the Horner syndrome is not really relevant, but it's just nice to know. The Pancoast tumor compresses on something called the sympathetic chain, which is found in this region, your subclavian region, okay? And since there's compression of the sympathetic chain, you have an overactive parasympathetic response in your head and neck, okay? So this is why the patients present with ptosis, which is drooping of the eyelid, miosis, which is constriction of the pupil, and hemianhidrosis, which is loss of sweating, basically. So mydriasis, which is the opposite of meiosis, is pupillary dilation, and this is a sympathetic response. You don't generally see neck edema in even in thoracic outlet syndrome because you're compressing on the subclavian vein, which drains blood from the arm. So you see edema in the arm, not the neck. And excessive sweating is also a sympathetic response. And yeah, so that's it. If there's a tumor above the horizontal fissure, which lobe will be affected? The answer is C. So again, it's a basic recall question. Um, but basically the right lung has two fissures. You have the horizontal fissure and you have the oblique fissure, okay? And the horizontal, so the question is asking, there's a tumor above the horizontal fissure, which lobe will be affected? So that this is the horizontal fissure, and if there's a tumor here, it will affect the superior lobe. If there's a tumor below the horizontal fissure, it would be in the middle lobe. And let's say there was a tumor above the oblique fissure, also, it would be middle lobe. And if there's a tumor below the oblique fissure, it would be affecting the inferior lobe, okay? So just main concepts you need to take away here is that the right lung has two fissures. You have the horizontal and oblique fissure. This actually came as an SAQ in our exam. Which one of the following structures is responsible for the lymphatic drainage of the lungs? Yes, the answer is A. I mean, it's in the name, bronchomediastinal, broncho for the bronchioles and mediastinal because you find your lungs in the mediastinum. If you're wondering why it's not cervical, for example, cervical lymph nodes drain lymph from your head and neck, and axillary drains lymph from your extremities and from your thoracic wall. It does kind of drain from your lungs, and same with subclavian, but it doesn't mainly drain lymph from the lungs. It's more of an indirect drainage. And so the answer is bronchomediastinal lymph nodes. It's in the name anyways. Like, why wouldn't you pick this? Um, this is the slide. And that's it for my section. If you guys have any questions, my contact details are at the beginning of the slides. And yeah, thank you very much. Mustafa, you wanna take over?
Yeah, sure.
All right.
Okay. And yes. Okay, Assalamu alaikum everyone. My name is Mustafa. I'm a second year medical student and I'll be taking over the second part of anatomy practice questions for your CVP final. Hopefully this session helps you guys in as a review for your final and you all should inshallah you guys will all do good. Just make sure you study properly and do a lot of questions for anatomy. Anatomy is mainly memorization, so if you do a lot of questions to reinforce your knowledge, then you guys will be all right, inshallah. And if you guys have any questions after this lecture, here are my contact details, my email and my number. Feel free to text me or email me anytime. And let's get started. A 50-year-old male presents to the clinic for a routine physical examination. Upon inspection, the physician notes that the majority of the sternocostal surface of the heart is formed by a particular chamber. Which chamber of the heart predominantly contributes to the sternocostal surface? Yeah. Anyone else want to answer? Okay. So the answer is C. How about if I was to ask you guys what makes up majority of the posterior surface of the heart, the back surface? Which one of these choices would it be? Yeah. Yeah, you're right. So the right ventricle is the initial answer. So the right ventricle right here, this is the sternocostal surface of the heart. It makes up majority of the anterior surface of the heart. Whilst the posterior surface, the back is mainly made up of the left atrium. For the diaphragmatic surface, which is also known as the inferior surface of the heart, it's made up by the right atrium, the right ventricle, and the strip of the left ventricle. So yeah, move on. Which of the following is a primary function of the pericardial cavity? What do you guys think? So the answer is actually D. So the question was just asking which of the following is a function of the pericardial cavity? So the pericardial cavity is basically the space between the parietal layer of the pericardium and the serous layer, and the visceral layer, sorry. And it's got four different functions. I've made this acronym right here, CLAP, which stands for P for protection, L for lubrication, A for anchoring, and P for prevention and overexpansion, prevention of overexpansion. So the answer right here was limiting heart dilation during diastole. Why does it do that? It basically reduces the endomyocardial tension of the heart. Protection, it protects it from other structures surrounding it, like the sternum or other mediastinal structures. It provides lubrication, so it prevents any adhesion or friction between it and other structures. And it acts as an anchor also and helps the heart stays in its right position, preventing it from moving anywhere. So those are the four functions. You guys could use this acronym if you want to. Let's move on. During cardiac surgery, the surgeon identifies a narrow passage within the pericardium, located posterior to the ascending aorta and pulmonary trunk. This passage is important for surgical procedures involving ligation or manipulation of major blood vessels. Which of the following structures is being described in this scenario? Yeah, you guys are right. It is B. transverse pericardial sinus. So the transverse pericardial sinus is basically the space that this person has put his finger into. It's posterior to the pulmonary trunk and the ascending aorta. That's what gave it away in this question. Yeah, right here. And it's of clinical significance. And another important passage you guys need to know is the oblique pericardial sinus, and it would be posterior to the pulmonary veins. So I guess these two sinuses are important for your OSPE. So yeah, it's just a pre-recall, it's just a pure recall question. Let's move on. A 60-year-old male presents to the clinic complaining of fatigue and mild dyspnea on exertion. On physical examination, the physician auscultates the heart and identifies the mitral valve. Where is the best location to auscultate the mitral valve in this patient? Yeah, you guys are right. And if I was to ask you guys to add a phrase to B, because B is the right answer, to further describe the location of the mitral valve, what do you guys say? Okay, the apex is correct, but location, like exactly mid-clavicular line. Because so this picture was from your lecture, um, and it is you do auscultate at the apex of the heart. That's relative to the clavicle. It's present in the mid-clavicular line, and in the exam usually, or Dr. Arkif usually involves the mid-clavicular line in the choices. Over here, I didn't involve it because it'll probably be direct and you guys would have gotten it easily. But make sure to remember it's the left fifth intercostal space mid-clavicular line. And these are the other auscultatory points for the pulmonary valve, aortic valve, and tricuspid valve. Next question. A 58-year-old male undergoes surgery to incise the ligamentum arteriosum for a procedure involving the aortic arch. Several days after the surgery, the patient presents with hoarseness of voice. What is the most likely cause of this hoarseness of voice in this patient? Yeah, it's an easy question. The answer is indeed A, the left recurrent laryngeal nerve. So the left recurrent laryngeal nerve branches off of the left vagus nerve and goes here and wraps around the ligamentum arteriosum and then goes back up into the larynx. And it's to supply all of the intrinsic laryngeal muscles, apart from one muscle. Which muscle does the intrinsic laryngeal? Which muscle does the left recurrent laryngeal nerve not supply? But did you guys understand the question? So basically, the muscle is the cricothyroid muscle. Um, moving on, the right recurrent laryngeal nerve. The right recurrent laryngeal nerve wraps around the right subclavian artery. They treat it as like a low yield question, but I'm sure that it came last year for us. So just remember that it does not hook around the ligamentum arteriosum, it hooks around the right subclavian artery. Let's move on. A newborn presents with mild cyanosis and occasional difficulty breathing. The physician suspects a congenital heart defect and orders an echocardiogram. The results show a small communication between the right and left atria, but no significant shunting of blood flow. Which of the following is most likely to cause these symptoms? The most likely cause of these symptoms in this newborn? What do you guys think? Yeah, the answer is indeed D, patent foramen ovale. What gave away in the question is that it's an open connection between the left and right atria, right here, and it's supposed to close after the baby's born. because the left atrial pressure overcomes the right atrial pressure, forcing these two doors open. I think you guys studied it in embryo. So basically, if it does stay open, it would lead to symptoms like cyanosis or difficulty in breathing. It used to be a shortcut, or was a shortcut in the baby, so it doesn't go to the right ventricle then back to the lungs because the blood was provided by the mother and it already had oxygen inside of it, so it didn't really need to go through the whole journey. So it would just take the shortcut, go to the left atria, left ventricle, and be pumped out. But if it's defective after birth, when the mother's not providing blood for the baby, it would lead to symptoms like cyanosis and occasional difficulty in breathing. Is that clear? All right, let's move on. Which of the following is not a function of the moderator band? Okay, anyone else want to answer? Okay, so the answer is D, anchoring the tricuspid valve. So the moderator band is the structure right here. It's connected to the intraventricular septum and the ventricular wall. So A, preventing overstretch of the right ventricle, is actually one of its functions because it's a connection between the intraventricular septum and the ventricular wall. So it prevents it from overstretching in diastole or when it's filling up with blood. So it's kind of like a stabilizer. Its other two functions are, you can see right here, the right bundle branch is part of the conduction system. A major twig of it runs through the moderator band, which helps it conduct the action potential to the rest of the ventricle. So it's important for the conduction system. Its third function is that it helps blood when it's going into the right ventricle and helps the outflow or helps or diverts its flow to the pulmonary valve and into the pulmonary arteries. So it kind of helps with the flow of blood, or in other words, hemodynamics. So those are its three functions. It was in these three choices right here. It does not anchor the tricuspid valve because that's done by the papillary muscles and the caudinal tendon. Is that clear? All right, cool. Let's move on. Which of the following effects is directly caused by the sympathetic stimulation of the heart? What do you guys think? Yeah, so the answer is B. I'm not going to explain the soul image, but the sympathetic nervous system is also known as the flight or fight system. So your eyes are gonna dilate, you're gonna be breathing faster. That's why your airways will relax, your heart rate will increase. So let's say you're in a scenario you're getting chased by like a lion. You want to run really fast, right? So the muscles in your legs are gonna require more oxygen and more blood to accommodate that. So right here, the heart contractility will increase. So the heart's gonna increase in heart rate, of course. Your heart will beat faster to help supply the blood for your legs, and your heart contractility will also increase, pushing it forcefully so it could reach your legs, so you could run as fast away from the line. And due to your heart also having cardiac muscle, it's also a muscle, it requires blood and oxygen. Your coronary arteries will dilate and increase the blood supply to the heart cardiac muscle so it can keep working. Yeah, for D, increased heart rate, that is correct, but decreased coronary artery blood flow is incorrect. So That's basically it. Um, any questions? Okay, let's move on. Wow. A two-month-old infant presents with a loud holosystolic murmur heard best at the left lower sternal border. Echocardiogram confirms a ventricular septal defect, and the physician is concerned about potential complications such as aortic valve insufficiency or atrioventricular conduction abnormalities. Which of the following locations of the VSD is most likely to be associated with these complications? Yeah, so the answer is B, the membranous part of the interventricular septum. So this question is really long. In the exams or the finals, they usually like to bring a whole big case to kind of divert your attention. But this question is really easy. And just by looking at like the last line or the last part of the question, you can kind of figure out what they're trying to ask and don't let them divert your attention. So basically, the membranous part of the interventricular septum, it takes up 1/3 of the whole septum, whilst this takes up 2/3, the muscular part. What helps me remember is that the muscular part has more muscles, it's more stronger. So membranous part is more weaker. Therefore, it's more prone to being defective in a ventricular septal defect. And also in the question, they did mention atrioventricular conduction abnormalities. The bundle of His does run through the membranous part of the interventricular septum, so it will lead to conduction abnormalities. So that's also an indication that this is the correct answer to. Or you could remember that the muscular one has more muscles and the membranous one is weaker. Is that clear? Okay. So the next lecture I'll be covering is the mediastinum. Do you guys have any questions about this lecture? The heart. Okay. Let's move on. Does the bundle of His also run in the muscular part? To my knowledge, it doesn't, but I'm not 100% sure. I will have to go back to the lecture and review it. So if you could like contact me after, I'll make sure to get the right answer and let you know. Is that okay? Okay, thank you. So mediastinum, let's go into it. A 50-year-old male with a history of hematologic malignancy requires a sternal puncture for a bone marrow biopsy. The procedure is performed at the midline of the sternum, just below the minibrucisternal joint. The physician accidentally directs the needle too deeply, potentially puncturing a major structure in the chest. Which of the following structures is most likely to be damaged if the sternal puncture is done improperly? Yeah, you are right. It is indeed A, the aortic arch. There is one more structure that is prone to damage. Do you guys know what other structure is prone to damage when a sternal puncture is done improperly? Yes, you are right. It is the brachycephalic vein, the left one. So this is the reference slide. They said the sternal puncture was done at the just below the minibrucisternal joint, and that's where the aortic arch is present. It goes right here, and it's right posterior to the sternum itself. And the left brachycephalic vein is also prone to being damaged if the sternal puncture is done improperly because it has to go diagonally from the left side to the right side so it could drain with the right brachycephalic vein to form the IVC. So it's also prone to damage too. Okay, next question. An infant born 2 weeks premature presents with a machine-like diastolic and systolic murmur heard over the left sternoclavicular joint. What will be observed in the infant as a result of this defect? What do you guys think? The answer is A. There will be blood flow from the arch of aorta into the pulmonary trunk through the defect. What's this defect called? Does anyone know? It's a bit long, so you could write like the shortened version of it. Okay, thank you. Patent ductus arteriosus. So it is indeed the patent ductus arteriosus. What gave away in the question was the machine-like diastolic and systolic murmur, and it basically it sounds like this because the left ventricle. So basically, what's in defect is the ductus arteriosus, and it's a connection between the aorta and the pulmonary trunk. So the left ventricle will try to eject blood into the aorta as hard as it can, and then blood will keep seeping through this defect, this ductus arteriosus, back into the pulmonary trunk. So it was kind of like a car trying to start up, but it keeps failing. So that's why it sounds like a machine. And these other choices are incorrect too. D, left ventricle to the right ventricle through the defect is referring to a ventricular septal defect. And C, the infant won't be cyanotic because it's mentioned here in your lecture, it won't be cyanotic because cyanosis is basically where the blood doesn't have enough oxygen in it and there is not significant mixing of deoxygenated blood and oxygenated blood, which would lead to cyanosis. There is, but there's not enough to the point that it would lead to cyanosis. And B, I think it's referring to stenosis. It has nothing to do with this question. So what basically gave away this question is this machine-like diastolic and systolic murmur. It's unique to the patent ductus arteriosus. Is that clear? Okay, let's move on. A 39-year-old Somali male presents with a persistent cough and shortness of breath. He has a history of hypertension and atherosclerosis. On physical examination, the physician notes a clinical sign and suspects a thoracic aortic aneurysm. Which of the following is most likely to be a clinical sign of the thoracic aortic aneurysm in this patient? What do you guys think? Okay, the answer is actually A, tracheal deviation due to compression of the aortic arch. So it's referring to a thoracic aortic aneurysm. This is the reference slide. So the thoracic aortic aneurysm is basically an enlargement of the aorta, and it would lead to it will tug or compress the trachea and lead to it deviating, and it deviates it to the point that it's palpable at the sternal notch T2. So the rest of these choices would be wrong. C, pulsatile mass in the neck. I think that's referring to some type of tumor, so that would be wrong. And increased jugular venous pressure due to right heart failure. That won't be a sign. That wouldn't be a sign of thoracic aortic aneurysm. I think you chose D because of this part of the question, but that's what they tend to do. They tend to trick you with the long case, and the most important part is the last bit of the question. So yeah, so C and D would be wrong. It's just a simple recall question. And an aneurysm in the aortic arch would lead to damage to the left recurrent laryngeal nerve and lead to hoarseness. We already discussed that, I think. Do you guys have any questions regarding this? Okay. Next question. The thoracic duct is the largest lymphatic vessel in the body. How much of the body's lymph does it drain, and where does it drain into? Yes, the answer is C. 3/4 of the body's lymph, left venous angle. If I was to ask this same question, but instead of the thoracic duct, I'm asking about the right lymphatic duct. Which one of these choices would it be? Yeah, yeah, you guys are right. It is 1/4 of the body's lymph, right venous angle. So, the thoracic duct is the main venous drainer in our whole body. It drains 3/4 of our body's lymph, starting as the cisterna chile at the bottom. It drains both of the lower extremials and then all the abdomen and the left side, sorry, of the thorax and the left side of the neck with the left side of the head. Whilst the right lymphatic duct does the other half of the thorax, the right side, the right upper extremity, the right side of the neck and the right side of the head. So and it drains into the junction between the left internal jugular vein and the left subclavian vein. And the junction is also called the left venous angle. This is probably high yield for your OSPE too. So please remember it. Okay, intercostal spaces. Do you guys have any question regarding this lecture? Oh, by the way, the mediastinum, it did have a lot of material regarding the structures present in the superior mediastinum and the anterior, posterior portion of the mediastinum, even the middle one. There's a lot of structures, and those questions are mainly recall. All I could advise you is to memorize them and or make silly acronyms for them. That really helps me. And they're probably going to bring a couple of questions from them. So please try to um, memorize them in any way you can. They're probably high yield. So yeah, intercostal spaces. All right, first question. An old woman receives an intercostal nerve block for rib fracture pain. After the procedure, she develops motor weakness in her upper limb due to complications. The intercostal nerve is located between which two muscles in the intercostal space? Yes, the answer is C. And what type do they help? Do these two muscles aid in inspiration or expiration? Just a bonus question. Yes, it is indeed expiration. MashaAllah, you guys seem smart. So I think Ahmed discussed this in a question too. They run through these two muscles, the internal intercostal muscle and the innermost intercostal muscle, and they run in the order of Van. The most vulnerable to damage is the intercostal nerve because it's the least covered by the rib. And yeah, that's basically it. It's just a recall question. All right, the next question. A patient is observed to have a bucket handle movement during deep inspiration. Which of the following describes the thoracic wall movement that occurs during this type of breathing? Yep, the answer is A. Increase of the transverse diameter of the thorax. So right here, the transverse dimension increases when the intercostal muscles contract on inspiration. And what the main ribs that show this transverse dimension movement is the bottom ribs, because they kind of flare out as we inspire, as we breathe in. And that kind of resembles the handle of the bucket being lifted slightly. So it just moves outwards to accommodate the lungs to expand and allow air to come in on inspiration. The AP dimension is resembles the pump handle movement, where it moves outwards and moves anteriorly and outwards, which increases the anterior posterior, the back and front dimension. And they are also caused by the intercostal muscles. As the vertical dimension is caused by the diaphragm contracting and pushing all the abdominal muscles down to allow the lungs to expand even more and allow air to come in. Okay, that's it for that question. Next question. A 45-year-old male is involved in a car accident and suffers multiple rib fractures, resulting in flail chest. During physical examination, the physician notes abnormal chest wall movement. Which of the following best describes the abnormal chest wall movement seen in flail chest? The answer is C. Loose segments of the rib cage move inwards on inspiration and outwards on expiration. It's written here. It's a pure recall question. It's very painful, and it also shows paradoxal respiration, which is similar to the diaphragm paralysis, I think, diaphragmatic paralysis. Okay. Next question. A 55-year-old male undergoes abdominal surgery, during which the T10 diaphragm opening is inadvertently damaged. Which of the following symptoms is most likely due to damage at the T10 diaphragm opening? What do you guys think? Yeah, the answer is indeed B. Dysphagia due to esophageal injury. So it's talking about the T10 hiatus. What other structures are at risk of getting damaged too, alongside the esophagus? If you are, the vagus nerve. And there's one more. It's the left gastric vessels. So I guess the slide is pretty high yield. You guys should remember them, even for the OSPE, if I'm being honest. In the T10 hiatus, you've got the esophagus, vagus nerves, both right and left, and the left gastric vessels that run through them. So they're most likely to get damaged. The other answers regarding hoarseness and difficulty in speaking due to recurrent laryngeal nerve damage. The recurrent laryngeal nerve doesn't even go through the T10 hiatus. It doesn't even go through any of the openings. So that would be wrong. C, chest pain and regurgitation of food due to esophageal motility disruption. This is regarding peristalsis of the esophagus, and it's irrelevant to the diaphragm opening. Shortness of breath and reduced oxygen intake due to diaphragm injury. And the diaphragm is not injured. The only thing that's damaged is the T10 opening of the diaphragm, so that's also irrelevant. So the answer would be dysphagia due to esophageal injury. Okay, the anatomy of the pleura. Do you guys have any questions regarding the last lecture? Okay. In resting inspiration, I think the diaphragm is the main muscle which is involved, but the external intercostal muscles could be partially involved in resting inspiration, but it's mainly done by the diaphragm. Okay. Okay. You're welcome. So the anatomy of the pleura. This is the last lecture. Um, First question. A 45-year-old male presents with a chest injury. The physician needs to auscultate the superior lobe of the right lung to assess breath sounds. Which of the following locations is most appropriate for auscultating the superior lobe of the right lung? Yeah, the answer is A, above the fourth rib. If I was to ask you guys the same question, but the left lung instead, what do you guys answer out of these choices? Yep, you are right. I was like that. And the middle lobe of the right lung, which one of these choices would it be? Yeah, mashallah. Guys seem to get it. So this is the reference slide. It mentions everything. It's above the fourth rib for the right lung to auscultate the superior lobe because of the horizontal fissure. It's only present on the right lung, when the left lung only has the oblique fissure. So it's to auscultate the superior lobe over there, it would be above the sixth rib. And for the middle lobe, it would be between the fourth and sixth rib, only for the right lung. And the inferior lobes, we would auscultate the breath sounds at the posterior chest, at the back. Is that clear? Okay, next question. An Faisal med student experiences sharp pain on respiration before the CVP final. He is diagnosed with pleuritis in the costal pleura. Which of the following nerves is most likely responsible for the sharp pain with respiration seen in pleuritis? What do you guys think? So the answer is actually C, the intercostal nerve. And basically, what what you should have focused or what you should focus on in this question is pleuritis in the costal pleura. So if there's pleuritis in the costal pleura, the intercostal nerves are the nerves that is the nerve that's gonna cause the pain because it provides sensory innervation for the costal pleura. Whilst if this question was to ask about pleuritis in the mediastinal pleura, it would be referring to the phrenic nerve. Okay, so this is the reference side. Pleuritis is basically the inflammation of the pleura, and it causes fluid accumulation seen in the X-ray. They're probably going to ask you about X-rays in the question. They're going to show you the X-ray, which would give you um, further a better understanding, maybe. There's right here, it says the costal pleura. Um, the local pain and pain and respiration would be caused by the intercostal nerve, whilst if the mediastinal pleura would show irritation, it would be the phrenic nerve, which causes the pain. And it would also cause shoulder pain too because of its root being C3, C5. Is that clear? So what you should have pointed out is the costal pleura. If it was the mediastinal pleura, then the phrenic nerve would be correct. Okay. A 30-year-old male is brought to the emergency department after being stabbed in Croydon, South London. On physical examination, he shows signs of respiratory distress and chest pain. An X-ray reveals that the lung appears collapsed. Which of the following conditions is the most likely cause of his symptoms? Okay, the answer is indeed C, tension pneumothorax. What gave away in this question was the lung appeared collapsed in the X-ray. In the exam, they're probably going to give you a picture of the X-ray so you could further choose the answer. But it's also important to focus on the wording of the question. There's so in pneumothorax, in this X-ray right here, we've got a bunch of black space, and that's showing us that the lung is not present in that space anymore. The lung has collapsed. And why has it collapsed? It's because the pneumothorax is mainly caused by penetrating wounds like being stabbed in the chest, which was mentioned in this question. And that basically leads to the parietal pleura being pierced through and allowing the pleural cavity being open to the outside. So air can move freely in. So as we inspire, or as a person with pneumothorax inspires, the lung basically goes and compresses the opposite lung and goes closer to the middle of our body. And as we breathe out, it expands and goes back to the area of the wound. A person has asked the question here, how did we rule out hemothorax? So what gave away this question could be referring to hemothorax because it did say that the person has had a stab wound to the chest. That's what gives away is the X-ray reveals that the lung appears collapsed. So that should be in bold, in my opinion. And as we could see here, the X-ray shows that the lung has been collapsed. I don't think the lung collapses in hemothorax. You would see accumulation of fluid in the pleural cavity, which is blood. So does that answer your question? They'll probably give you the X-ray in the exam. I just didn't want to put it in the question because you guys would have gotten it easily. Mashallah, you guys are smart. All right, cool. Okay, this is the last question, if I'm not mistaken. A male with pleuritis is experiencing significant pain and discomfort due to a pleural effusion. The physician decides to perform a thoracentesis to remove the fluid from the pleural cavity. At which location should the needle be inserted to safely perform the procedure? What do you guys think? Okay, the answer is B. No. Does anyone else want to answer? Okay, the answer is actually C, the eighth intercostal space mid-axillary line. So the question was asking about where would we find the area or where would we insert the needle if you want to eject fluid, right? For fluid, we do insert the needle between the seventh and ninth intercostal space mid-axillary line. Whereas if you want to eject air, it would be in the second intercostal space mid-clavicular line. And the needle should be placed closer to the upper border of the rib to prevent injury to the neurovascular bundle. Ahmed kind of mentioned it, so yeah, that's basically it. So if they asked you to remove air, it would be A and not C. Is that clear? All right, cool. So thank you guys for tuning in. This is the end of the anatomy practice question part. Hopefully this session helped you guys. And good luck for your CVP final. I know you guys will do amazing. Just spam out questions and study properly. Thank you all. And you guys could ask me any questions. All right. Bye. Salam.